Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thanks for listening to Behind the Knife. This is Patrick Georgioff, and I want to share an important message. Our oral board review kicks ass. We have over 100 scenarios with top-notch commentary to get you prepared for the exam, or maybe even just prepare for your next rotation. We're also adding over 30 new scenarios this fall and a brand new interactive video feature so that you can practice for the real thing. Get quick and easy access via our app for on-the-go use. It's still the best, and it is still significantly less expensive than anything else out there. Group discounts are available. Now, enjoy the episode and dominate the day.
Hello and welcome to Behind the Knife. Once again, we have another awesome collaborative episode with our partners from across the pond through the Association of Surgeons in Great Britain and Ireland, where we take a deep dive into the many facets of surgery and compare how things are done here in the United States as well as in the United Kingdom. If you've tuned into our earlier episodes, you know that we welcome expert guests from each country to enlighten us on what it's all like. At the end of the episode, you as the listeners get to decide for yourself who does it better. I'm Jon Williams, one of the Behind the Knife Fellows, and I'm excited to once again have both Kelly Bateman and Jared Wolgamut from ASGBI co-hosting with me. Kelly and Jared, care to introduce our topic for today's episode?
Yeah, I'd love to. So I'm Kelly, from ASGBI, a surgical trainee in Wales, and I'm really excited that today we're going to be discussing sustainability and green surgery. We know it's becoming an evolving hot topic, especially in the UK, and we know that healthcare contributes sort of 4 to 5% to greenhouse emissions globally, with our operating theatres contributing over half of this. So there's definitely plenty of room for improvement there. So today we're going to explore what some of the issues are and hopefully find out some solutions to reduce the waste and emissions from both sides of the pond.
And hello, I'm Jared, a surgical trainee in Scotland, and I'm delighted to introduce our UK expert, Mrs. Cleo Kennington. She is a big fan of the podcast, but more importantly, she is a consultant emergency general and trauma surgeon at St. George's Hospital, London, and was the recent ASGBI Sustainability Lead. In America, you'd call her Dr. Cleo Kennington or Professor Cleo Kennington, but in the UK, we call Mr. and Mrs. for our surgeons. She's a big advocate for practicing what she preaches, focusing on how we can reduce the environmental impact at all stages, including cycling to work, preventing complications and unnecessary surgeries, to reducing the use of disposable surgical components. Welcome to the podcast.
Thank you.
All right, and for our US-based expert, we're excited to have Dr. Ben Miller with us. Dr. Miller is a general and minimally invasive surgeon at the Cleveland Clinic with a clinical focus on complex abdominal wall reconstruction. After earning his MD from University of Minnesota School of Medicine in 2011, Dr. Miller went to Nashville to complete his general surgery residency at Vanderbilt University Medical Center. Following this, he became a MIS Complex Ab Wall Fellow of the Cleveland Clinic under Dr. Rosen, after which he joined faculty in 2023. In addition to his clinical interests, Dr. Miller also has a deep passion for sustainability efforts within surgical practice, carrying on the legacy of established sustainability efforts within surgical care at the Cleveland Clinic and training the next generation of sustainable surgeons. Dr. Miller, thanks so much for joining us.
Thanks for having me.
Lovely. So perhaps we can kick things off with some of the basics. Where do the emissions in surgery come from? And what does sustainability in surgery look like? Where can we get started? Mrs. Kennington, why don't you start with what we know from the UK?
So what we know from the UK is the carbon emissions from an operation don't just come from the theatre. There's everything around it, including the patient's journey to the hospital, how many visits they have before the operation, as well as even thinking about the staff travel and how staff get to the hospital, focusing on public transport and active travel. But if we're thinking more in this podcast about the actual operation itself, there are 3 main sources of carbon hotspots. That's the anaesthetic gases. So the halogenated anaesthetic gases actually have a global warming potential up to 2,000 times that of just CO2. And so a lot of work is undertaken, especially with the anaesthetists from the UK, looking looking at ways to reduce this. So an important thing we as surgeons can do is to think about using local anaesthetic, but also the gases used by the anaesthetists are being looked at. We know that desflurane is the worst anaesthetic gas, so there's loads of work done in the UK to reduce the use of desflurane and switch where possible to intravenous anaesthesia. The next carbon hotspot in the operating theatre is energy use. We use a lot of devices in theatre. There's a lot of computer systems also with the anaesthetic machines. But the biggest energy is from the HVAC system, the heating, ventilating and air conditioning system that keeps the operating theatres at the right temperature and with airflow. And one of the ways that you can save the most carbon within the operating theatres is to think about switching those off when the operating theatre is not in use, because it only takes 20 minutes for those machines to power on and get the operating theatre go in action. And often the theatres aren't working overnight. So work is going on within the UK to be able to switch those machines off overnight. And then finally, the third highest CO2 source is from the single-use consumables, and we use loads of those in the operating theatre. So it's really looking at where you can switch from single-use to reusables. So whether that's with the drapes, the gowns, and then many of the instruments. And when you can't use reusable instrument, you may sometimes using hybrids, so instruments that are partly reusable and partly single-use. And I use those for my ports for laparoscopic operating. And then there is a small amount of energy use from heating the water for scrubbing and for sterilising of the instruments. But compared to those first three, that's much less.
Thank you very much for that, Ms. Kennington. I think that's really laid the foundations of our understanding in some of the key issues that we face in surgery. And Dr. Miller, we know that the US has the highest healthcare emissions globally. And why do you think that is? How does that compare to the UK? What can we do about it? And why should surgeons care?
So America does generate a lot of greenhouse gases, and the healthcare industry plays a big role in that. I think U.S. healthcare generates somewhere between 8 and 9 or 9 to 10% of our annual greenhouse gas emissions. And surgery is a big contributor, right? We don't actually know how much surgery contributes to that number. And so but to back up a little bit, your question about why American healthcare generates so many greenhouse gases compared to other countries is a good one. I don't know how much, the UK generates or how much less the United Kingdom generates than America, but I'd be curious to know. I think that, of the global carbon healthcare footprint, America generates about a quarter of it, if I'm not mistaken. And we don't, I don't think we have a quarter of the world's people, so it should be smaller than that. First, surgery is resource intensive, right? We know that the operating room uses 5 to 6 times more energy per square foot than other areas of the hospital. We use half the hospital's supplies. We generate 30 to 70% of the hospital's waste. So anything that's going on in the operating room is using a lot of resources and generating a lot of greenhouse gases. And we are incentivized in America to do things, especially to do healthcare stuff in general, and especially to do operations, because that is how the hospital generates most of its revenue. And so we as surgeons are always asked to do more operations, to see more patients, and we generate more greenhouse gases doing that. And so I think that we don't, to be fair, we don't know exactly the carbon footprint of American surgery. That number is unknown, although I would someday like to get to the bottom of it. But we do know that overall, that the carbon footprint of healthcare is huge, and a lot of that is driven by surgeons and surgery. And why should we care about this? Because this affects all of us, right? It affects Americans, it affects our communities, but it also affects people across the planet. The greenhouse gases that we emit here are felt everywhere. And we know that greenhouse gases, that fossil fuels are burning and sort of is supercharging the greenhouse gas effect, and this affects patients across the world, and it worsens outcomes of people who have cardiovascular and pulmonary diseases. It changes the distribution of vector-borne diseases. There's even some evidence that we know that heat-related illnesses are rising, and there's some evidence even that heat causes increased violence, even when accounting for seasonal variability. So I think that we should care because we're doctors and we're people, and we should care about other people around the world and how the delivery of surgical care in the United States is potentially worsening healthcare outcomes across the world.
Okay, well, of course, it's vitally important to consider the environmental impact of surgical care, but it needs to be kept under the wraps of the broader context of cost. We could propose all sorts of green initiatives, but our managers won't approve of it unless it's cost effective or even cost saving compared to what we do at the moment. So, Dr. Miller, maybe we should start with you. You've just described how expensive things are in the States and how you're incentivized to do more. But how do you think healthcare economics influences sustainability? And what are the implications of costs in attempts to make surgical care more sustainable?
I would say that luckily, this is an area where they typically align often. So to make things more sustainable in general, we try to make them reusable, right? Like every time you need to put a t-shirt on, you don't go buy a new t-shirt. You wash you wash your t-shirt and reuse it. And so I think the same thing applies to surgery, and especially with textiles in the operating room. And so if something is reusable, you pay for it one time. Like we don't, when we do a laparoscopic case, say, we don't open all brand new laparoscopic instruments. We reuse the instruments we have, or even an open case, any case. And because it's cheaper that way, right? We invest some capital in instruments and then we wash them and reuse them, which makes sense. And so I think that a lot of the most impactful sustainability initiatives involve just simply reusing things instead of buying new things. Unfortunately, we live in what's often called a linear economy, right? Where healthcare industry is incentivized to sell you things forever and ever and ever. And so they want devices and textiles to be disposable so that you have to buy new ones for your next case. And so, but anyway, the more we can get toward reusable things in the operating room, textiles and instruments, the more money we save. There are other logistical supply chain issues with some reusables, laundering, sterilization, and I get that. But most of the time, you save money by purchasing something up, maybe a little more upfront cost. With Dr. Kennington referred to trocars, right? So using reusable trocars, there's extra sterilization costs that may go into that. But overall, the big picture overall is that in the long run, by using reusable devices and textiles and items, you typically save money instead of spending more money. And the last thing I'll say is that when it comes to supply chain shocks, right, like we saw during the pandemic, your system, the healthcare system, is much more resilient if you're not relying on disposable items. If you have a system, a circular economy set up locally where you can use something and then clean it and reuse it, and you don't have to rely on something shipped in from overseas that are susceptible to supply chain disruption. So it's another reason to switch to reusables. It saves you money and makes your healthcare ecosystem more resilient.
That's really interesting. So you're basically saying you need to spend money to save money, but that implies you need money in the first place. Mrs. Kennington, in the UK, are we able to invest in capital in our hospitals, buying more surgical equipment that is reusable rather than maybe the case-by-case cheaper alternative of buying single-use items, but the longer-term expense of single-use items? Do you think we are good in the UK at reusing instruments and buying good kit?
So I think every hospital is different, but I know at my hospital at the moment, we're doing a lot of work. And what we're trying to do is, yes, we need a little bit of money up front, but each project we do, we then demonstrate how much money we're saving. So, for example, they bought a whole load of reusable theatre hats for all the staff. And not only were they reusable, they also had the staff's name on it, which helps a lot with team working. I don't know about anyone else, but I'm not very good with names. And because there's so many people in the team, they all know my name because I'm the boss, but I don't know their name. So I found it really helpful having everyone having the name on their hats. But then that saved us loads of money over a period of time on on disposable hats that we've really made sure we calculate that. So we've then been able to reinvest the money that we've saved into the next project of doing different things. So it's a kind of self-fulfilling prophecy of saving money of each different project that we're changing on, then using the reusable instruments and things.
Just a side question then. It was mentioned that in the US, there's a lot of incentive to do more, operate more, specifically operate. In the UK, we don't have that same pressure, do we? I mean, your wage unless, private work aside, your wage doesn't go up if you do more and more operating necessarily. So how would you approach that conundrum?
I mean, I feel not just for operations, but we're incentivized to reduce costs. So developing protocols that are very clear of when you need to intervene and when you don't, to try and identify when you wouldn't need to intervene. And because I know, I guess for me, I know I'm not going to lose income from not doing the operations. It helps me to have those conversations without feeling pressured to make the patient to undergo the intervention. For example, there's a big push towards shared decision making, where we're recommending to talk about benefits, risks, and alternatives, and what will happen if we do nothing. So the patient has a real understanding of the treatment needed. And a lot of the time, using this process, the patient then opts not to have the operation, which may be the best outcome for the patient, because there's a lot of evidence that a large number of patients have regrets of undergoing treatment. So if you're going to do an operation for a patient who then has regrets, that's a real waste of carbon. So it's really important to make sure that we don't do operations when they're not indicated.
I think that's such a fascinating aspect that I've never really thought of through a sustainability lens, which is, like providing the correct care for the patient and having a shared decision-making conversation and things like that. And I think that's actually really contributes to a compelling argument for, thinking critically about the indications for a given intervention. As Dr. Miller mentioned, our system is built around a fee-for-service value system that, whether it's conscious or not, does incentivize interventional therapy. But I do think that, if you add sustainability to the equation of also, doing the right thing for the patient, not subjecting them to the obvious risks of a given operation as well, you can do a lot more harm than good, but not just for the individual iteration of care, but for the environment at large. So this is really helpful. I think we did talk quite a bit about this concept of reusable items and instruments and things like that in the OR. I do think that, my humble experience as a trainee right now, it's pretty blatantly obvious that a lot of medical and surgical innovations don't take that into primary consideration at the same time. You develop the fancy fenestrated endovascular device for aortic reconstruction, but that's a single use item and costs probably more than I make in a year. So, just things that I think maybe should be more at the conscious forefront for innovations as well.
So one of my partners just came up with a device to help us with abdominal wall reconstruction, and he worked with the Cleveland Clinic to build this new device, and now he is working on patenting it, and he is showing this device to industry. Their question for him, because industry works in a linear economy, works best for them in a linear economy. Their question for him was, what are any of these? The device is totally reusable. Everything is totally sterilizable, totally reusable. And they asked him, as he's pitching this device to them, well, could we make any of these components disposable? Because then every time you use it, then you have to pay more to use it. So I think our priorities are not aligned. I think they could be aligned better with industry, but that is, may require policy changes, require a lot of work to get us all on the same page. But that's sort of the reality and situation with, surgery and our industry partners.
I don't know if this is going to work, but a big part of the NHS net zero kind of policy is working with industry, and they have sort of a timeline where they won't, because the NHS is such a big organisation for procurement. What they've said is that the industry has to comply with their net zero goals for us to be able to buy from them. So it's a real push to industry to make more sustainable equipment. Where I see that failing is what you've just said about, I think that industry is going to say, oh yes, we are producing it in a net zero way, but we're still making it as a single use. So I don't know if it's going to work, but I'm hoping they're making progress on it.
There's something about the United States and having industry, healthcare delivery, and the government being all on the same page that seems to be particularly challenging. So moving on, I know we talked a lot about this concept of reusable items and also a really interesting take on indications for interventions versus, making shared decisions with a patient also with a sustainability mindset. What are some other kind of core areas of sustainability to be gained that you see within surgical care?
I think of this in sort of three domains. And I think of this in the operational domain. where we practice clinically, and that's most of what I do. And then there is the educational domain, where we teach medical students and trainees and other staff about how to deliver surgery in a way that's more environmentally friendly and to care about these issues. And it's one thing to learn about them, but it's another thing to change behavior. And we could have a whole podcast on that, I think. And then the third domain is research. And what are we doing to learn more about the intersection of climate change and surgery? And so I think that surgeons, academic surgeons in particular, are well positioned here because this is what we do every day, right? I work in a clinical realm and educate trainees every day and do research as part of my job every day. And so I'm thinking about these three areas continuously. And so it's easy to transition sustainability into these three domains. And as far as the operational domain goes, there are easy ways and more difficult ways to transition to a greener operating room. And we can talk about those things later on. As far as education goes, I think that, it's the department, the institute, the state. I think there are like macro, meso, and micro levels of involvement here. And I think surgeons can play a role at each of these levels to get to build a culture of sustainability and to get engagement from trainees and other surgeons. And then as far as research goes, I don't know that there's going to be much federal funding for climate change research in the next few years, but there are still studies ongoing, and we're part of those things, and we have a pretty robust research group here. And so I think questions to answer are for reprocessable instruments, for example, like a reprocessable surgical harmonic scalpel. Those are available, and some people are hesitant to use them because they worry maybe they impact that maybe they have higher failure rates, or maybe their wound morbidity will be higher if they use one of those. And so, what doesn't exist out there is for example, like a clinical trial comparing a reprocessed device to a new device, and does that have an impact on clinical outcomes like wound complications? And so these are things that we can explore and should explore, but there's a lot of work to be done.
This might be a complete sideline, but even in the realms of solar panels, electric vehicles, for many years, for decades in Europe and America, there were government incentives to buy these things. And now those government incentives are decreasing and decreasing as the price of these things comes down. And eventually, and possibly it's already happening, that the amount of government subsidies that is required for these things is essentially non-existent because they have become market viable compared to a non-sustainable alternative. So I don't know, hopefully we get to that point in the healthcare industry as well.
I think building from that, particularly Ms. Kennington, what do you think about how clinicians can help influence more industry and government to get those more sustainable items and to think about the bigger picture in things from some of your experiences so far?
I do think influencing industry can be very difficult because they don't want their remanufactured instrument to be used. They want you to be using the single-use one. So I think it's it has to come from the clinician wanting these things. The one thing that I haven't found on the market, which makes sense to me, is a reusable stapler. So at the moment, the staplers, they are reusable because in the same patient, you can use the staple numerous times. You just get refill cartridges. And I don't know why they can't make a stapler where the stapler can go for resterilisation, and then you obviously have single-use cartridges for the next patient. So to me, that's one area that you could make a low-cost stapler. Potentially, there's a lot of talk about using it in these innovations in the developed world because they can't afford to buy the single-use items, but they are kind of wanting to do more healthcare. So maybe that's where these devices may become more used and tried and demonstrated that they are effective, and then we start using them more in the developed world.
I think Dr. Kennington is right. I think that surgeons have a lot of power here because the only things that are being used in the operating room are the things that we are asking for. And so we can be better about asking for reprocessed or reusable devices. I don't know how much influence I have over, sort of macro level and industrial and healthcare policies, but at a very micro level, we do have a lot of influence. And I think that we can work with with our supply chain as well, and the administrators in the hospital to try to make more sustainable decisions. And like we talked about before, most of these things, if you can show that there is a cost savings, and for a lot of these things, there is a cost savings, even for using, reprocessed devices. The reprocessed device is usually cheaper than the new device, and you can demonstrate significant, a place like the Cleveland Clinic, which was a huge enterprise, you can show significant cost savings by using reprocessed devices, for example. So I don't want to sound like I don't want it to sound like surgeons can't have any impact here. There are a lot of things out of our control for sure, but in the end, like, it's you and the patient in the operating room with your team, and you're making the decision whether or not to use, a device. So I think that in the end, our choices matter, and the teams we build matter, and we can have an impact.
Thank you. Yeah, I think it's focusing, isn't it, on some of the small things that we can do to sort of help feed into that bigger picture, particularly as surgeons. Sometimes we're a bit resistant to change. We like the quick wins. Focusing on that sort of clinical domain, have you practiced or got any other examples of sort of simple things that we can all do day to day to improve sustainability in our work?
So I have like a hierarchy of things I think about, from easy things to do in a hospital or hospital system, and then down to much harder things. And the easy things to do, Dr. Kennington, she pointed out a lot of these already. So, if your operating rooms have setbacks, so set them back when they're unoccupied. Turn the air changes down. Let the humidity and temperature drift out of their required ranges. So there are ways to save money in the HVAC system that way. And then you can reduce your red bag waste. I know this is a little controversial, but we found that just changing the size of the canister to a smaller canister instead of a giant canister that's convenient for everyone to fill, it gets people to think about putting less normal waste in the red bag waste. And so I think reducing red bag waste is another easy way, another low-hanging fruit to reduce your overall waste and the emissions associated with disposing of red bag waste. And then you can start a recycling program where you can recycle high-value plastics and some cardboard, and we have a program like that, but it's required a small grant. So those are harder things to get started. And then you can start a reprocessing program. I know that Stryker Sustainability would love to come into your hospital and start a reprocessing program just about anywhere. They put a bin in your OR and you collect all the reprocessable items, and they do it for free. So, and it's up to you whether or not you want to buy back those items, but it's an easy way to prevent them from going into the landfill. And then you get to things like other things, maybe easier, streamlining your surgical sets, although, whether or not 1 or 2 instruments make a huge difference, I think is debatable. I think you have to somehow shrink the size of the overall tray to make a big difference, because the sterilization process is what's generating most of the greenhouse gases. And in my experience, the hardest things to change are the textiles, and not even the sterilized textiles, just the non-sterile textiles. These things can be very difficult because of the logistics involved, right? The laundering, getting them, the transportation back to the hospital, getting them restocked. So on the order of the hierarchy of easy things to do to hard things, I think that's kind of how I look at it. But there are tons of low-hanging fruit in your hospital to take advantage of, and I would encourage people who are interested in this to start with something small, something easy, build a team, and work on changing just one small thing.
Thank you. I think, that was very inspiring, giving us all a few ideas. And Mrs. Kennington, have you got any other ideas? Or I know there's been a lot of college initiatives and college pushes for sort of rub, don't scrub, the green surgery checklist. Would you like to expand on some of those films?
So I think a lot of what the colleges have been working on what Dr. Miller was giving examples on. There's two examples that I'd like to describe, which seem simple ideas that can make a difference. The first one, it actually was started in Great Ormond Street Hospital, which is a paediatric hospital, by the infection control team. So I've noticed, especially coming through the pandemic, that there's been an increased use of using non-sterile gloves for everything. Every time you go anywhere near a patient, or even if you're not near a patient, people put on a new pair of non-sterile gloves. And actually, they don't make any difference for infection control. The important thing is to wash wash your hands. And so what the infection control team at Great Ormond Street did was a campaign to say, you don't need to wear these non-sterile gloves. And I don't know how it works in the US, but definitely in our operating theatres, for every time the patient is moved from trolley to operating table and back again, every time the team around the operating theatre do anything new, they put a new pair of non-sterile gloves on. And that is just not necessary unless you're touching the mucous membranes of the patient. Having these non-sterile gloves does not reduce infection. So this campaign in Great Ormond Street, they massively reduced the amount of gloves they use, saving loads of plastic that there was avoided going to landfill, as well as saving them loads of money. But I think one of the important things that they showed was that it was good for the patients, so that the kids were reporting that they were actually really scared of people coming at them with these blue gloves on. And so when they were just normal people, that with a touch of their hand rather than the plastic, the patients had a much better experience. And so that's a simple change to reduce waste and improve patient care. And so this campaign from Great Ormond Street, it has been approved in many hospitals. So certainly within even in our intensive care unit now, we don't need to wear gloves when we're going up to patients in the intensive care. We only if we're going to be doing intimate examinations or getting in contact with bodily fluids. So I think that's a simple change that can make a difference. The other one that is maybe slightly less impactful, but a change that I've made recently is in the use of Incopads. I don't know what they're known as in the US. I know in Australia they call them Blueies, but Incopads are quite big, bulky things that have plastic in them, and they're single use. And usually in each operation, you use quite a few of them, and they all get thrown away at the end of the operation. And so certainly for laparoscopic cases, you use them to wrap the arms around to the side of the patient. They're used once and thrown in the bin. Somebody showed me that they are actually the same size as a pillowcase. And so I've asked the team to my theatres to use pillowcases instead. And so now, instead of throwing these Incopads away at every operation, we use a few pillowcases, and they get washed, and then we can use them again for the next week.
So you brought up before, only doing necessary operations, and I totally agree with you. And I think that this is a kind of a controversial area of minimizing unnecessary operations. And I think, if we take a step back, if we all just stopped operating, we would drive down the greenhouse gases emitted by surgery to zero. And if we only did absolutely necessary operations for people with free air or bleeding or whatever, then it would increase a little bit. But, for me, most of what I do are hernia repairs, and those are a quality of life operation. And so I think that we have to be a little careful about this idea that we only do necessary operations and stop doing unnecessary operations. I think it's hard to define an unnecessary operation sometimes. And I think that I would hope really that only the most unscrupulous surgeons would be the ones doing operations that are not indicated. I think that even surgeons who are doing a lot of operations, even in America, are doing operations that are indicated. And a lot of those operations here are for quality of life. Another area to look at is to think about not necessarily reducing the number of operations or only doing necessary operations, but I think another way to consider this is to talk about reducing, and I think Dr. Kennington referred to this earlier, reducing low value care and improving the quality of our care, right? And so as we improve the quality of our care, we drive down complications, and complications are expensive, not only to the hospital and to the patient, but they also generate they have a huge environmental impact. And if we can reduce low value care, things that we do like preoperative testing, preoperative or postoperative imaging, or even in-person visits sometimes, where we ask people to drive a really long way so that we can look at them and do a cursory exam, then maybe something that's more easily accomplished with a virtual visit, something like that. So I think that there are ways to improve the value of our care and drive down our carbon footprint, but at the same time providing high quality care to patients who can really benefit from operations, even if it's a quality of life operation.
I think you both alluded to it a little bit, which is another aspect, is having sustainability champions or individuals who are, minded towards sustainability. So surgeons who just have a passion for this and share this with their colleagues. I think that is one of the things in the current hospital that I work in at the moment is extremely effective. There's one surgeon in particular who, she'll kill me if I say her name, but she's brilliant. She is made huge changes in our institution, including introducing reusable gowns and reducing all sorts of waste. She's also focused on reducing single-use gloves and single-use instruments. And even when she's not there, people will say, don't let such and such know that you're doing this or that you've used second gloves and so on. So, putting a poster on the wall of the latest checklist or going through a checklist could be useful, I suppose, but putting signage up doesn't always work. People just ignore it. But having an individual who people know is passionate about this, in my experience so far, it's worked really well at keeping everyone in line and in check.
I think you're right, Jared. I think that having a champion changes the culture of your hospital. And when the culture changes to one that prioritizes and normalizes sustainability, that's when you get engagement from everyone, from more staff, from trainees, from administrators, from the allied health personnel like the scrub techs and the nurses and the CRNAs, everyone else involved in the care. If you have someone who values this and makes this like a visible priority and is interested in this and is motivating people to change their behavior, I think you can change the culture in a place. And that I think is what makes sustainability more sustainable, is changing the culture.
Oh, well, great. It's great to hear all that's being done to improve sustainability, both here in the UK and also across the pond. I think a key question is, where do we go from here? What do you think the future of sustainability in surgery looks like, and how can we grow these efforts?
So I think it's putting all these ideas into action, making sure that we do think about all of these things every time when we're operating. And although I agree with Dr. Miller, just because it's a lifestyle operation doesn't mean we shouldn't be doing it. But I think we need to be very careful about thinking about only doing operations when they are beneficial and the patient understands the benefits that they might get from the operation, but also thinking about how we can prevent the patient from needing the operation. And so for me as an emergency surgeon, often when the patients come in as an emergency, it's a real teachable moment. They're very scared, and they have a lot of respect for us as doctors and surgeons, and they listen to the advice that we give them. So really using that moment to advise them to stop smoking and increase exercise and improve their diet. And those are some of the things that will reduce complications and reduce the need for surgery. But also I know in the US they do a lot more than we do in the UK about optimizing pre-surgery to reduce complications. And I hope that we can do more of that in the NHS, especially as we have such long waiting lists. So use the time when the patient's on the waiting list to make sure that they're optimized and they're fit for their operation to reduce complications. So hopefully we can do more of that in the future.
I think Dr. Kitchen is exactly right. I think if we can improve the quality of care we deliver and reduce low-value care, it improves patients' outcomes, improves their satisfaction, and drives down the cost of care and drives down the environmental impact of the delivery of surgical care. And then, beyond that, how do we get everyone interested in this? I think that in a perfect world, everyone rides their bike to work. All the patients they ride their bikes to the hospital, and we use all reusable instruments, reusable textiles, and the operations are short, and everybody goes home the same day without staying in the hospital. But I think that that's not totally realistic in my lifetime. But one thing I will say is that I think that as the effects of climate change become more apparent in the United States and globally, I think people will become more interested in learning how to mitigate this. And like we talked about in the beginning, we're seeing a rise in interest in this even among surgeons, which I think may be the last group on earth to care about this. So it is reassuring that surgeons are finally caring about this and are motivated to make some changes. And so I think we keep working to find ways to reduce our greenhouse gas emissions, to work with industry, to develop policy, to work among our societies. I know that SAGES and EAES have taken position statements on this recently, and the American College of Surgeons is interested in writing a position statement on this as well. So I think that we get people on board and we stay motivated and make changes in our hospitals at the local level, make changes nationally and internationally. We'll continue to move the needle on this.
All right. Well, this has been an incredibly enlightening discussion. So thank you both for all of your expert input on that. Both of you mentioned that this growing interest in these sustainability concepts are certainly occurring and prudent. So for our listeners out there or anyone else that's early in their career, whether it's a current trainee or just out of training, who might have found this or other sustainability efforts as inspiring as we have, do you have any words of wisdom for folks that are interested in sustainability and surgery for kind of getting involved in this space, maybe for the first time?
I think that you can start by building a small project at your hospital, making it a team. And if you want help, there are tons of resources out there. So Healthcare Without Harm is definitely willing to help you get started. Practice Green Health is a consultant group, and they can help you get started. And there, at the society level, there are people interested in helping you as well. So if you're a general surgeon involved in SAGES, there is a sustainability committee. And if you're part of the American College of Surgeons, the college has all these communities that you can be a part of, and there's a sustainability community now. And I think more than anything, like just talking to people who are interested in this and finding a community of people to collaborate with, both in your hospital, but also across the country in your discipline is important as well. And you can share ideas, share successes, share things that didn't work so well and changes you could have made. And so I think that there are lots of ways to get involved from, in a society at a kind of a micro level.
Yeah, and within the UK, and on a similar level within the ASGBI and within your societies, but also within your hospital, like Jared was suggesting, find a champion within your hospital to help you with your projects. And there are lots of ideas. Other sources are the Green Surgery Report has lots of ideas of sustainable projects that you can do, as well as looking at the Green Theatre checklist from the Royal College of Surgeons.
Well, that wraps up our deep dive into sustainability efforts in surgery in both the United Kingdom and the US. I hope that all of our listeners found this as informative and inspiring as we certainly did. Now that you've heard both sides, you as the listener get to decide who does it better, the UK or the US, of course. We'll leave it up to you. Thank you, Mrs. Kennington, and thank you, Dr. Miller, again, for spending your time with us and for sharing your experience and expertise. We certainly do appreciate it. For the listeners out there, stay tuned for more Behind the Knife ASGBI collaborative content coming soon. And as always, if you have any thoughts, questions, feelings, or comments, please feel free to reach out to us at hello@behindtheknife.org. Mrs. Kennington, do you care to do the honors to send us off?
Dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple iOS and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.